looks like it's about time to get started. So welcome everybody. This is our late fall webinar for the special interest group in the mild traumatic and concussion section of the International Brain Injury Society, also known as IBIA or IBIA. My name is Dr. Chiswick. I'm from the University at Buffalo, and I'm one of the co-chairs of our special interest group. If you have any questions about our special interest group or about IBIA, feel free to message me or email me. But I'm very excited to welcome our two presenters today. And I do quickly want to mention in the chat with Jen, you'll see that we have a couple of upcoming conferences, which I've talked to Melissa and Abby about too. NABUS is accepting abstracts right now, which is our North American Brain Injury Society. The abstract submissions will end on the 11th of this month. So if you're interested in submitting, get them in very soon. That conference is in Washington, D.C. next year, March 9th through the 13th, but the conference proceedings will start on the 11th. Then we have our Pediatric Brain Injury Society, or IPIS. The abstracts are due for IPIS on the 18th of this month, so once again, relatively quick. If you have any questions about that, feel free to reach out to Jen or I. That conference will be April 29th to May 2nd next year in Calgary. But without further ado, let me introduce our speakers. We have Dr. Melissa Anderson. Melissa Anderson is an assistant professor in the Department of Exercise Physiology at Ohio University. She is the director of their concussion research group and a co-director of the neuromuscular and biomechanics group in health assessment. We also have Dr. Abby Baldwin here. She is a physical therapist and a founder of Get Your Head in the Game. This is a group that focuses on concussion and lower body injury prevention strategies. She is also the director of Next Step Physical Therapy. And without further ado, I'll turn it over to both of you.
Thank you to the Concussion Special Interest Group for inviting us to share our work. As Haley said, my name is Abby Baldwin. I'll be presenting today alongside my collaborator, Dr. Melissa Anderson from Ohio University. And together we'll share how concussion disrupts the body's sensory motor systems, why this disruption may increase ACL injury risk, and a female athlete-specific neuromechanical model based on our recent study findings. So I am based in Delaware, where I work full-time as a clinician specializing in concussion rehab. A few years ago, I started an initiative called Get Your Head in the Game to help athletes understand the link between concussions and lower body injury risk. And last summer, I connected with Dr. Anderson, who's the assistant professor at Ohio University, director of the Ohio Concussion Laboratory, and co-director of the Neuromuscular Biomechanics and Health Assessment Laboratory. Together, we developed the project we'll be sharing today, a theoretical framework that offers a new way to look at injury risk in contact sport athletes, and it's informed by what we know about concussions and whiplash. Over the past few years, research has shown that concussions increase the risk of lower body injuries. Female athletes are disproportionately affected, sustaining both more concussions and ACL tears than their male counterpart. This is a unidirectional relationship, and with ACL tears becoming increasingly devastating in women's sports, there's urgency to understand the connection. fMRI studies help explain why concussions increase lower body injury risk. During a leg press task, athletes without concussion history showed a direct connection from the left inferior parietal lobule to the primary motor and sensory cortex. Athletes with prior concussion showed compensatory activation in brain regions responsible for concentration, visual integration, and somatosensory processing. This pattern illustrates neuromechanical decoupling, delays in brain-muscle communication that disrupt perception-action coupling and increase injury risk in sport. This fMRI study was repeated in athletes with known magnitudes of repetitive head impact exposure across a season in contact sports. The same pattern emerged. Higher exposure to repetitive head impact was linked to more neuromechanical decoupling. This shows that even subconcussive impacts affect the brain's efficiency in turning sensory input into motor commands, which are critical for executing high-level movements athletes need in sport. To focus on female contact sport athletes, we developed this model to guide our framework. Female athletes are more vulnerable to whiplash and concussive forces in their sports. Whiplash reduces proprioceptive input to the brain and compromises ocular motor control. These effects also occur after concussion, and concussions also cause neuromechanical decoupling due to maladaptive neural networks where brain-muscle communication is delayed. These consequences of whiplash and concussion, decreased proprioception, impaired ocular motor control, and delayed motor commands, increase the risk of lower body injury in contact sports. Female-specific vulnerabilities include hormonal, muscle activation strategies, and anatomical differences. All of these factors contribute to why female athletes may face higher injury risks. But for our work, we wanted to highlight the modifiable factors. So that brings us to differences in the cervical spine, which we believe can be addressed through targeted training. When we look more closely at the cervical spine, there are some important differences between males and females. Females tend to have smaller necks relative to a larger head, which changes the way forces are distributed. They also show that females have lower neck strength values in every plane of motion compared to males. Structurally, females have about a 17.5% smaller vertebral body width, which means there's less bony support and a greater predisposition for the head and neck to displace after impact. Here's a quick visual of how that translates. These two springs have the same compression force, but different diameters. This illustrates the male versus female neck. With contact to the body or directly to the head, there are greater whiplash forces in the smaller diameter spring. On top of that, forward head posture, found in 80% of college females, further inhibits the deep neck flexors that are needed to decelerate the head. These disproportionate muscle balances in forward head posture increase the magnitude of whiplash. And when you add in neck pain or headaches, these stabilizing muscles can be even more compromised. All of this together creates a functional disadvantage that we need to address. So those factors present in female contact sport athletes lead to a more substantial exposure to whiplash forces and concussive forces in sports. And impacts are an unavoidable part of sport. But what if we could train the female neck to have the neuromuscular control needed to decelerate the head on the neck to be better prepared for the demands of the game, and turn impacts like this one on the left to ones like this one on the right by targeting the correct muscles? Carrie Peake's research has shown that even simple neck exercises, training the athlete to catch their head as they roll back, can meaningfully change the mechanics we're targeting. Athletes demonstrated reduced head impact magnitude when taking an impact to the front of their head, such as when heading the ball. And with training the neck, there were also lower rates of possible concussive events. So while targeting the deep neck flexors clearly helps mitigate whiplash forces, the benefits go beyond just slowing down the head. Strengthening these muscles also supports proprioception and ocular motor control, which are critical for reducing injury risk and improving performance. This muscle group not only controls the head on the neck position after impact, but it also plays a key role in proprioception and eye movement control. A quick way to measure upper cervical proprioception is through neck or joint repositioning error test. The athlete is seated 90 centimeters from a wall with a head-mounted laser. First, we mark their perceived neutral position on the wall. With the eyes closed, they move into cervical extension and then return to what they believe is neutral. If the difference between those 2 points is 7 centimeters or greater, it indicates compromised upper cervical proprioception. Julia Treleaven has extensively studied the upper cervical spine and the consequences after whiplash. Her work outlines key sensorimotor disturbances, including decreased cervical proprioception, compromised balance, dysfunctional eye movements, sensorimotor mismatch, and each of these disturbances directly connect to the injury risk factors we see in contact sport athletes. The top chart illustrates the neuromechanics of how these changes occur, and then the bottom graphic highlights that the threshold for whiplash and the expected consequences is much lower than the threshold for concussion. This means that at even lower impact forces, we still see the arthrogenic inhibition of the deep neck flexors, leading to the cascade of consequences associated with whiplash. Dr. Hikosaka published an important pathway that connects deep neck musculature to eye movements. His work explained the remarkable density of mechanoreceptors in the deep neck flexors and the synaptic route that contributes to the VOR, or the vestibular ocular reflex. The deep neck flexors' dense mechanoreceptors, along with the upper cervical facet joints, sends afferents to the vestibulum, to the vestibular nuclei, then to the flocculus and the cerebellum, where it then transitions to an efferent signal, which goes back to the vestibular nuclei, which engages the VOR through the abducens and oculomotor cranial nerves. Arthrogenic inhibition of these components after whiplash and contact sports is inhibitory to these contributions to gaze stability. Concussions share many of the same consequences as whiplash, such as compromised proprioception and impaired ocular motor control from the reduced upper cervical afferent input. But in addition, concussions disrupt ocular motor skills from a neural circuitry standpoint, in the same way we described earlier with neuromechanical decoupling. The key insights came from fMRI, which made the brain's compensatory activation patterns visible. But realistically, we can't run every athlete through an fMRI at the start of every season or after each head impact. But what if we could leverage something that we're already looking at in a more objective way? We already rely heavily on eye movements to understand the severity of a concussion. But if we leave this as only symptom-based assessment, like the VOMs, we're missing an opportunity. Eye movements can tell us much more. They can reveal the efficiency of neural networks and areas of disruption in the brain. An athlete can get to the point of symptom-free with the VOMs, yet still carry the hidden vulnerabilities that increase the risk for future injury. By using computerized objective ocular motor data, we have the chance to capture these hidden deficits and better protect the athletes. So instead of stopping at, does this make you dizzy, nauseous, or give you a headache, we can capture objective data. How fast, how accurate, and how long the visual system holds up. Those metrics reflect the efficiency of the underlying neural circuits, giving us a clearer picture of residual deficits and injury risk beyond symptoms alone. There's a tremendous amount of information that is gathered with each component of eye movement. Smooth pursuits, saccades, VOR, convergence, anti-saccades. But for the purposes of our presentation, we'll just isolate one eye function, the horizontal saccade. So for example, when an athlete performs a leftward saccade, the command begins in the frontal eye field of the right prefrontal cortex. That signal then travels through a defined network of synapses, and the left cerebellum ultimately places the eye on the target. So the right frontal lobe tells the eyes to move fast, and the left cerebellum catches it. The chart at the top shows an example of a horizontal saccade, with the left eye in blue and the right eye in red. And from the computerized interpretation of that movement, we gather key data points, such as reaction time delays, if they are overshooting the target, undershooting the target, or if their fixation is not stable. So once the eye gets where it's supposed to be, is it still on that target? Each of these errors, overshooting, undershooting, or fixation instability, provides insight into which part of the cerebellum is not performing optimally. The cerebellum has a large contribution to single leg balance, so we can use the functional carryover of where these deficits are based on where the saccade lands in the context of single leg balance. So if the athlete is undershooting, such as the chart circled in yellow there, that would be linked to the dorsal vermis. They would show a consistent position error in single leg balance, such as falling to the same side each time. If the athlete is overshooting, such as the chart in purple, this is linked to the vestigial nucleus. This athlete would have difficulty maintaining an upright trunk alignment in single leg balance. And then lastly, a poor fixation shown by the wavering lines is in the green chart. This would be linked to the flocculus and the cerebellum. So we would see slower or less effective corrective responses in single leg balance. Now, although circuitry of eye movement is complex, it's also incredibly revealing. These patterns give us a roadmap for training. It'll show us exactly where to target interventions to create greater neural efficiency and ultimately reduce the athlete's future injury risk. So more broadly, when the eyes don't land accurately on a target during a saccade, it indicates an ipsilateral cerebellar hypofunction. Another broad generalization is that cerebellar hypofunction compromises single leg balance stability. So here's an example of an athlete who had returned to full participation after a prior concussion. When we look at his horizontal saccades, we already see abnormalities. To connect this functionally, here is his balance on an RX. He's going to start off with his eyes open, and on his right leg, once he closes his eyes, he's going to show a consistent error, repeatedly needing to place his other leg down to stabilize. This points to a dorsal vermis dysfunction, and that's consistent with the undershooting pattern in his saccades. Now he's going to switch to his left leg. He'll start off with eyes open, and then he's going to switch to eyes closed. As soon as he closes his eyes, we're going to see his errors are more postural, with his trunk alignment being the main issue. This pattern suggests a vestigial-nucleus compromise, which is tied to the trunk control errors. He also has compromised fixations on both eyes, further showing susceptibilities to proprioceptive delays. Both of these dysfunctions would increase his injury risk. Poor single leg balance is already recognized as a risk factor for ACL tears, but when you add in trunk alignment errors on top of it, that risk becomes particularly elevated. Making connections between ocular motor control and neural efficiency is already familiar in concussion assessment and management because the eyes give us a window as to what's going on in the brain. If we want to identify where concussion management and return to sport with future injury risk may be falling short, we can look at this overlap in neural circuitry. When components of ocular motor control are dysfunctional, we have corresponding dysfunction in executing lower body motor firing patterns. So essentially, we can use the cumulative mapping of ocular motor functions to understand where an athlete may be experiencing neuromechanical decoupling. Every athlete brings some degree of injury baggage into a season, whether from a prior concussion or whiplash, and with that comes a hidden, lingering risk for lower body injury that we can't see through symptoms alone. We can have athletes starting off their season like the chart on the left, indicating a high level of neural efficiency, or like the chart on the right, indicating some possible evidence of neuromechanical decoupling and compromised balance. By identifying which area of the brain is slow to engage or may need targeted intervention, we can gain clearer insight into where that injury risk lies and how to address it before it becomes a problem. So can we leverage these relationships to see a decreased risk of concussion and protect against future lower body injury risk? Our hypothesis is that targeted deep cervical muscle training improves neck strength, proprioception, and ocular motor control, which will reduce future injury risk. The key question is whether concussion amplifies female-specific ACL risk, and if so, can targeted interventions help? By screening and strengthening sensorimotor systems, we may be able to reduce not only concussion incidents, but also ACL injuries in female athletes. So, given these risk factors for injury, we wanted to test whether a targeted intervention could strengthen female athletes' cervical and sensorimotor systems to reduce downstream injury risk. Dr. Anderson will explain how we researched that with the D1 women's soccer team.
All right, thank you, Abby, so much. So you've already heard the theoretical rationale. Let's walk through what we did and our findings. So building on the theoretical framework you just heard, our goal was pretty straightforward. We wanted to test whether a short 6-week targeted neck strengthening program could actually change measurable risk factors. Specifically, we looked at neck strength, cervical proprioception, and ocular motor control. We conducted the study with 29 Division I female soccer players during their pre-season training period. The intervention lasted 6 weeks, and all of the athletes completed both baseline and follow-up testing. Almost half of the athletes reported a prior history of medically diagnosed concussion, but we found that this factor didn't alter the overall effects of the program, so we ended up analyzing the group as a whole. For strength testing, we used a handheld dynamometer, secured the torso with straps to make sure that the trunk didn't contribute too much. Athletes performed flexion, extension, and combined lateral flexion with rotation on both sides. They were instructed to push into the dynamometer pad as hard as they could until a second beep signaled peak effort. We recorded both the maximal force they produced and the time that it took to reach that peak force in seconds. Altogether, the testing was very efficient. It took approximately 2 minutes per athlete, which makes this very feasible for use in team environments at the pre-season level. To assess cervical proprioception, we used the neck repositioning error test, which Abby previously described. In brief, we had athletes wear a lightweight head-mounted laser that was pointed at the wall, and they were seated 90 centimeters away from the wall. They were first asked to find a neutral upright position, and we used a sticky note that was marked with a circle to indicate where that neutral position was. Then they went into full neck extension so that their nose was pointed towards the ceiling. And while keeping their eyes closed, we asked them to return to their starting neutral position. And that new position was marked with another sticky note. We measured the linear distance between their starting and ending position, and any distance greater than 7 centimeters indicated worse proprioception that was outside of normal limits. We assessed ocular motor control using the iSync virtual reality headset, which is able to provide us with objective, validated tracking of eye movements in real time. Our athletes completed a series of tasks, including smooth pursuits, horizontal and vertical saccades, the vestibular and ocular reflex, and visual motion sensitivity. From these, we captured metrics such as saccade timing error, spatial error, lead lag percentiles, and VOR gains. The entire test only took about 8 minutes per athlete, and together these measures allowed us to evaluate how well the visual and vestibular systems were integrating with cervical proprioceptive input, not output, I'm sorry. Now let's talk about the intervention itself. The intervention was a 6-week sport-specific neck strengthening program. Guided sessions were built right into the team's existing strength conditioning workouts, focusing on deep cervical flexors and stabilizers. To reinforce these adaptations, the athletes also completed short, self-directed sessions on the field 3 to 4 times a week using bands and towels. Our goal was to target eccentric control and rotational stabilizations, movements that are especially relevant during heading and or absorbing contact. Importantly, the program was brief, practical, and easily implemented within their normal training schedule. The resistance was quite low, but I would like to stress that the athletes did say that this was challenging. So we began at a very low resistance of 1.3 kilograms for weeks 1 through 3. At week 3, our athletes were saying, oh, this isn't quite as challenging as it used to be. So we did up the resistance slightly to 1.7 kilograms for the remaining 2 weeks of the intervention. Finally, we also wanted to capture the athletes' perceptions of the program. At the end of the 6 weeks, they completed a short questionnaire about their experiences. The questions focused on whether they actually felt stronger, whether they thought these exercises were challenging, if they thought they were worthwhile, and importantly, did they feel more confident in their ability to head the ball? We received feedback from the coaches that this was a team that, although it is a high-level Division I team, they were very hesitant to take opportunities to head the ball. So we wanted to see, was there measurable distance on how they were performing on field? All right, and the best part, the results. So we saw very significant results, differences when it comes to our neck strength. our neck flexion increased by about 50% and neck extension by about 15%. Combined left rotation and flexion increased by approximately 45%, and our combined right flexion by about 40%. So once again, this is about 15 to 20 minutes of training for 6 weeks only. Now, to put these neck strength findings into perspective, the average soccer ball weighs about 0.43 kilograms. When it strikes the head at roughly 32 kilometers per hour, which is a realistic game scenario, that translates to nearly 14 kilograms of impact force applied to the head and the neck. So why is this such a big deal? Well, at our baseline time point, only one of the 29 athletes was able to generate enough force of their neck in flexion to stabilize their head upon impact. So the 14 kilograms of impact force is represented by that horizontal red line. After our 6-week intervention, all but 4 athletes were able to generate that much force. So we saw a huge increase in their strength over just a month and a half. So why is this such a big deal? We saw stronger, faster neck muscles that were able to help absorb and control the impact, reducing head acceleration and stabilizing the body's response. In our study, these improvements translated into real-world confidence. Every single athlete reported feeling more capable and confident in their ability to head the ball after training. They also reported that they thought this was worthwhile, and everyone reported feeling stronger. That combination of biomechanical protection and psychological readiness is critical for performance and safety. We saw a 28% decrease in neck repositioning error. Pre-intervention, on average, their neck repositioning error was 12.6 centimeters. After their intervention, it went down to 7.6 centimeters. This change indicates improved cervical sensorimotor control, with our key takeaway being that athletes demonstrated improved ability to return to a neutral head position without visual input, simply by training those deep neck muscles. Now, big, important takeaway, what about their ocular motor results? We saw some really meaningful changes here. After the 6-week program, athletes demonstrated reduced spatial error, meaning their eyes were more accurate in tracking targets. We also observed an improvement in the lead lag percentile, with the team moving from about the 52nd percentile to the 82nd percentile. That reflects faster and more efficient eye movement coordination. Perhaps most importantly, saccade timing error improved in both directions. Athletes were quicker and more precise when redirecting their gaze. These changes are relevant in soccer, where players constantly need to scan the field, track the ball, and respond to unanticipated movements. In other words, the intervention didn't just make their neck stronger, it appears to have enhanced the way their eyes and their brains process and react to visual information during play. With another key takeaway, neck strengthening enhanced athletes' visual tracking and reaction speed, likely making their eyes faster and more accurate on the field. Looking ahead, the next steps involve conducting longer-term studies with larger sample sizes to really test the durability and generalizability of these effects. We also want to expand beyond neck strengthening alone to explore how this fits into a more comprehensive injury prevention strategy. One key component will be injury tracking. Now, an interesting finding that I want to talk a little bit about, but really have a caveat that this was a single team. On average, Division I women's soccer teams usually experience about 1.8 concussions per year as per the NCAA reporting. At Ohio University, our athletic trainer reports experiencing 2 to 3 concussions per year that she medically diagnoses. But during the 2024 season, This is when our program was taking place. The team reported 0 concussions. While we can't claim causation from this single season, it's an encouraging signal that supports further investigation. Now, transitioning into our case studies, we had the opportunity to see this framework in action. Shortly after preseason testing, 2 athletes sustained non-contact injuries. Both had a history of concussion, had completed return to play protocols, and were fully symptom-free. So based on standard of care, the multifaceted concussion management program, they were good to go. Because we had collected ocular motor data before the season began, we were able to review their tracings. Nothing in the traditional preseason screenings would have flagged either athlete as at risk for a lower body injury. Yet both showed distinct ocular motor profiles, so distinct from their other teammates, providing further evidence that the eyes truly are the window to the brain, and that these patterns can reveal where neuromechanical decoupling may increase injury risk. I'm going to pass it back over to Abby, and she's going to take some time to explain to you what we saw when we reviewed their ocular motor reports.
So as Dr. Anderson mentioned, shortly after the preseason testing, 1 athlete sustained a non-contact left ACL tear. We found through their ocular motor tracings, we can advance on to,
Sorry.
oh, you're good. We found evidence of reduced efficiency in her left cerebellum, which could explain her susceptibility to a left-sided injury. In the top chart, her left visual field shows clear compromise in smooth pursuits as her left eye consistently comes off the target in the lower left quadrant. The movements are inaccurate and show no corrective adjustments over time. So smooth pursuits rely on the posterior parietal lobe, middle temporal area of the visual cortex and frontal eye fields, but the cerebellum is responsible for making those real-time corrections. Her left eye also demonstrated overshooting and poor fixation in her leftward saccades. So together, these findings of altered smooth pursuits, poor fixation in her leftward saccades, and overshooting indicate the left cerebellum inefficiency, specifically in regions affecting postural stability and rapid proprioceptive adjustments. So this pattern increases her risk for left lower limb balance instability, which is a known precursor for non-contact ACL injury risk. Another ocular motor measure of particular interest in contact sports is the antisaccade. So this athlete scored significantly lower on their antisaccade test compared to the rest of the team. Antisaccades provide an objective measure of visual reaction time, concentration and executive function, and most importantly, impulse control. So impulse control underlines the go, no-go response in sports. This makes antisaccades especially valuable for understanding injury risk from a neuromotor perspective. The second athlete sustained an injury shortly after preseason testing and suffered a left meniscus tear. For this athlete, both the right and left eyes showed variability in smooth pursuits and saccades, though the deviations are much more pronounced on the left side. Of particular note, the wavering fixation in the left eye, which suggests a delay in reaction time to proprioceptive information. And this kind of neural lag can increase injury risk during rapid changes in direction, turning, or deceleration. She also showed a low percent correct in her antisaccades, indicating compromised impulse control, and her performance revealed greater difficulty suppressing reflexive left-sided saccades compared to the right. So in the only 2 athletes who sustained time loss injuries that season, we saw a consistent pattern. Smooth pursuit errors were more pronounced on the side of injury, compromised saccade accuracy on the side of injury, fixation instability on the side of the injury, and poor impulse control across both cases. These shared findings strengthen the link between ocular motor dysfunction and neuromechanical decoupling, highlighting the potential to identify injury risk before it appears on the field, especially in female contact sport athletes who experience more whiplash and concussion than their male counterparts. These athletes began their season with no obvious indicators of injury risk, except for history of concussion. We know that sustaining a concussion increases an athlete's likelihood of a non-contact lower body injury 4 to 11 times, occurring anywhere from 90 days to 2 years after returning to sport symptom-free. By leveraging the ocular motor data, we may begin to uncover the hidden mechanisms behind non-contact injuries, particularly ACL tears, which continue to plague women contact sport athletes.
All right, so as we wrap up our presentation, we really want to stress what we believe to be the multifactorial benefit of deep flexor recruitment and strengthening these muscle groups, as it can improve proprioception and ocular motor control. So what we found is that targeted neck training is feasible in a team setting. Our 6-week program was easily integrated at the Division I level, and we had high adherence and high buy-in. We also saw substantial increases in neck strength, ranging between 15 and 50%. Also, our athletes were able to generate force faster, preparing them to better able to stabilize their head during impacts. Our proprioception was improved, and we saw that neck repositioning error decreased by approximately 28%. And our ocular motor control showed meaningful gains, specifically with reduced spatial error, higher lead lag percentile, and faster saccades. These findings together suggest that stronger necks improved integration between visual, vestibular, and proprioceptive systems. All right, so this concludes our presentation. Before we open the floor to discussion, we would like to thank the folks that make this work possible. Between Abby's team and my team here at Ohio University, we are both really lucky to have such a great support network. And speaking for myself, I'm really lucky that Abby has decided to collaborate with us here at Ohio University, and really looking forward to continuing to work together. We have a few other projects that are in progress right now, and can't wait to share the results of those as well. So at this time, we'd like to invite you to ask any questions.
Thank you guys so much for that wonderful presentation. For the duration of the question period, I'll kind of act as a moderator here. I do already see a question in the chat, so I'll field that one first. We have a question about the specific exercises you had your soccer players doing. This is from Whitney Herrera.
I have those pulled up here. If would you like me to share my screen here, Dr. Anderson?
Sure.
All right, I'll share here. Okay, so this is the main intervention on the left is what they would do independently prior to practices or competition. So they were using a TheraBand, originally a yellow one with a lighter resistance and then eventually red. So the athletes would tuck their chin, elevate their head about an inch off of they were using the benches on the side of the field. They would then rotate, do the same thing, chin tuck, elevate just a little bit. This was really the bread and butter of the study. They were recruiting this muscle group on a regular basis and essentially turning this on. With the level of strength that we saw in the preseason testing, we really just needed to teach these athletes how to recruit this muscle group. In the strength and conditioning sessions, we had recruitment of this muscle group in a more functional context. So soccer players need to be able to jump and head the ball. So we use this as a combined recruitment and skill-specific activity for them to do. And then we also had them recruiting this muscle group in a partial squat, going side to side. And again, we were focusing on mainly engaging the muscle group more so than an intense strengthening regimen.
Awesome. Thank you for that response. I think that answers Whitney's question. And Noelle, other people, if you do have comments, questions, feel free to put them in the chat. If you do want to pop on, you can give me a raised hand, and then, I'll let you guys talk directly to the presenters if you're interested. I'm also curious about the what's next question. So I know we kind of talked a little bit about what you're doing within soccer, but I'm curious if you're also going to look at other women's sports or other populations, specifically the older and younger athletes, because their susceptibility to lower body injury changes based on their age and experience.
Yeah, so I can take that question, Abby, if you're okay. So we have another project that we're wrapping up right now. We saw huge improvements for our female athletes. So we are curious if athletes that had a stronger baseline strength of their neck, because potentially they're recruiting more of those superficial muscles, if they would still benefit from targeting those deep flexors. So we just are wrapping up a project right now in which we worked with the men's and the women's basketball team, because they experience a lot of whiplash injuries as well. So we're doing our post-intervention assessment next week. So we are expanding to work with men and women to see if the benefits are, for both sexes. And then as far as working with different age populations, Abby and I are developing a program for older adults right now to see if targeting these muscles can help older adults and potentially mitigate fall risk as well.
Yeah, that's very interesting with fall risk. Can't wait to see the next project. Keep me in the loop on that. There is another question in the chat. This one's from Jake McPherson. The first one's a question and then there's a correction. So with the combined rotation lateral flexion, is it possible to understand how much SCM versus deep neck flexor activation is occurring? Correction, with the combined flexion plus rotation lateral flexion, is it possible to understand how much SCM versus deep neck flexor activation is occurring? i.e., could they compensate with SCM versus recruiting the deep neck flexors?
So for that test position, it's not possible to truly differentiate just because we can't study that muscle group with an EMG. However, from the functional context, we do know that we need those deep muscles to kick in first to truly stabilize the head on the neck. So with looking at our straightforward flexion, we get the most information about the capacity of that muscle group. So for instance, if there's high latency, like takes a while for them to reach their peak force in that plane of motion, combined with weakness, we know that that muscle group is not contributing as much as it ought to. But to truly isolate what's superficial contribution versus deep, we can't do that necessarily, but we can just gather information about the functional performance.
Hey, great. Thank you for that too. And if there are any questions, again, the chat is open, but I'll take this break to answer another one of my own questions. I'm curious about repetitive head impacts and the role that they might play in terms of causing these deficits. As you were presenting a lot of the pathways that we see in the brain for activation, I was curious about their root cause. I'm wondering if maybe they're physiologic, are these potentially genetic, or are these caused by repetitive head impacts, considering that these folks are engaged in contact sport, and if you would expect to see different performance between different sports based on contact.
That's a great question. How do we really know how much we're influencing here? So like how much is just what the genetic information carries about that athlete? With as drastic of a change as we saw with 30 athletes, it kind of points us back to this is just an underengaged, undertrained muscle group. For strength values to jump that much and then have consistent improvement in cervical proprioception and ocular motor control, it does allow us to understand that even if that was possibly just part of the genetic predisposition, are we helping to enhance the contribution from the cervical afferents? Which I kind of think of it as we have evolved so much in athlete development, but it kind of stops at the shoulders. The neck is such an important part of how the athletes engages with their sport, with their eye control, their anticipation, their threat detection, that regardless of what we know about what the population has at baseline, we saw an enhancement. So it really gives us encouraging information about what we could do to incorporate this into traditional training.
And
Awesome.
potentially we could have these meaningful results that could encourage strength conditioning coaches to include this in their training programs. So many female athletes do not want to train their neck. They are very reluctant to have a thick neck. During our baseline assessment, we had multiple athletes on the soccer team express concern that they were going to suddenly become, really meaty on their neck. They didn't want that to happen. And surprise, that did not occur from 6 weeks. But just by training them how to turn their neck muscles on, we saw these huge improvements on their eye's ability to track an object, on their ability to know where their head is in space. So we just hope that this is some compelling evidence that this is something that is feasible. It's really easy to integrate, and this should be part of their training program. I've never been involved in a study where every single finding was significant. So it was really exciting as a researcher. Yeah, it was really something cool. And like Abby said, just in 6 weeks, we were teaching them how to turn these muscles on. That's all we were doing.
Yeah, absolutely. Your findings speak for themselves, and I think there's a lot of strength in the research that you have, and I'm hoping that you'll reproduce those findings or get similar corroborative data in your next work. There is a question here from Michael Kroc as well. He is wondering, will the soccer team and or other athletes at OU get baseline screening to identify potential vulnerabilities?
Yes, so we had such great results when we did this with the women's soccer team last year. I do concussion baseline testing with every single NCAA sanctioned sport here. So I included it with every single test this year. So I have baseline neck strength in those four planes, neck repositioning error, and then an instrumented virtual reality assessment for approximately 500 athletes right now. So we can identify those who are at risk. So that's the ultimate goal. We're not quite there yet, but I'm building this repository now. So we have this data to see, all right, are there people that go on to have an injury? Looking back, what did their baseline measure look like?
Absolutely. We do have another question from Whitney Herrera. She's curious about the repetition number for the exercises which you presented. She's noted that she's very interested in practical application of this program in her patient population.
I believe for the one that they were doing independently, it was 2 sets of 10. Is that correct?
I think it was 2 sets of 10, and then in the weight room, it was 3 sets of 8.
Okay, and I'll give a second in case anybody has any last minute questions, but I've gotten all of mine answered. Otherwise, thank you so much for joining us, Melissa and Abby. It was a pleasure to have you on. And if anybody has any questions, your contact information was on the screen. One more question I see popping into the screen as I'm closing up here, which is totally fine. Jake always asks great questions. Cost of an ice sink. Do you guys know how expensive the device is?
So the device is between 12 and 15,000 for the first year, and then 10,000 for subsequent years. Now, cost is a massive consideration. However, in elite programs or universities like Ohio University, purchasing some sort of device, there's several available to get ocular motor data, can be used throughout their hundreds of athletes. So the cost kind of self dilutes across as many athletes are benefiting from the screening and follow-up testing.
Great.
Also, something to consider is they are under subscription models. So if you work at a university, that might need to be something that you have to negotiate. So they are subscription-based models. So Neuroflex is another brand option. The price is very similar, but it does give you the same metrics. But iSync is what we used for this specific project.
All right, great. And Whitney is also curious if there's a recording of the presentation today, which I can segue into. So there is a recording of the presentation currently ongoing. It's available after the presentation for people who have registered. Otherwise, if you are a student, because I know Melissa and I both have a couple of students who we invited as well, and you need to reach out and contact us, we can work on getting a recording over to you, and Jen will help us do that. There is another question here from Jack as well. Jack says, great presentation. Appreciate the field expediency of the intervention. 2 questions for you. Did you have a familiarization session at the very beginning? Have any concerns about learning effect influencing your results? I'll start with question 1, and then we'll go to question 2. I closed out way too early. We have a lot to go over still.
So familiarization for what we were doing and why, we relied on the team captains. So we met with them to explain the premise as to why does this matter, went through implications for performance and also the protective side. Learning effects influencing the results. So that's a great question. On the ocular motor side, I can say for certain that we don't have a learning effect because it is purely an instinctual reflexive response. For instance, if I have a concussed athlete, I can test them once, retest them 10 minutes from now, and I'll get the same results. In terms of neck repositioning error, we did not test that except for the 2 times 6 weeks apart. So they didn't have much exposure to the practicing or learning effect of that. And it's just been a reliable test to be the most insightful for cervical proprioception. Strength, not really concerned about learning effect there. Again, just recruiting those muscle groups. Do you have anything to add to that, Dr. Anderson?
I don't think so. I think you covered it very well. And I do want to emphasize this was very much led by the team. Like we wanted to empower the team that this is something that you're running. So we leaned on our captains quite a bit and our strength conditioning coaches. Like I wasn't over there at their sessions, at their practices every day saying, you have to do this. We really trusted them. We took roll. I had a research assistant go over there and check people in, but they really took ownership over this project. And we got great feedback from the athletes. For example, we had feedback from a goalie say, I should have gotten a concussion during the specific game when I went to dive for the ball, but like I was able to not knock my head on the ground. I like noticed that I kept my neck stiff. So like feedback like that was great. So they had a lot of ownership over the program itself. As far as the neurologic changes, morphology, 6 weeks. So we stopped at 6 weeks because we were very lucky that the coaches allowed us to intervene when they were in preseason. So our soccer team here has a very, very short preseason before they go into competition. So we wanted to find a sweet spot. So 6 weeks was our sweet spot. We knew that that's needed to have these adaptations take place. So that was our deal. More than 6 weeks, that would be great. So that's something that we're playing with our basketball intervention right now. We are also conducting or collecting fMRIs to try to see some of the underlying neural circuitry changes that occur after this training, because we want to understand, all right, how is this driving this change? So as far as the underlying neural changes, hopefully we can talk about this next year if we get to give another talk. So we don't quite understand what happened, but we know that something happened.
All right, I'm looking through the rest of the comments and it looks like we have a lot of thank yous, and I'll extend the same thanks back to you guys. Thank you so much for sharing your time and your information with us. Without any other questions, I do think that we can wrap up early. Oh, wait, no, every time I say that, I see that Whitney Herrera raising your hand to ask a question. So go ahead.
Yes, thank you. Sorry, I was really slow to try to type this in, so I thought I'd just say it out loud. I'm really curious. So I know that in the presentation, you're using the iSync to track, okay, here's an abnormality. We're going to do an intervention. And then based off of doing that intervention, we know that there's decreased risk. Are there certain cutoffs or values that you're working from off the iSync, or is it just a comparison from their baseline to the improvement at the end? Like, how are you using the metrics specifically, I guess, is my question.
That's a really good question. So to clarify for the study part, we didn't intervene specified on their iSync findings. We were essentially just gathering data because our expectation was that recruiting the deep neck flexors would improve gaze stability, saccade timing, things like that. However, looking back on that, from my perspective as a clinician, I strongly rely on iSync findings or ocular motor data to guide rehab strategies. Through doing so, I see certain tendencies if somebody is hypermetric or hypometric, how I can correlate that with VOR gain to understand what the contributions are to their functional movement patterns. So as of right now, we don't have a protocol, so to speak, that if somebody is hypermetric on the left and has decreased VOR gain to the left, we don't have something that says this is what we need to do to fix that. That's something that I think Dr. Anderson and I are going to continue to keep our eye on, because this is just a revolutionary way to understand that mystery behind non-contact injuries, especially in contact sport athletes who are continuously exposed to whiplash and concussion forces. So that part is yet to be seen, but something that we are very interested in.
Great, thank you so much. Yeah, we are, so I'm in the realm of concussed soldiers. So we're trying to figure out similar things, but for our patient population, and like, are there better metrics, objective metrics for when someone is safer to return to sport, and whether or not there's application, like if, and to my knowledge, I'm not sure, and this is just a, a deficit in my own knowledge, is can iSync one accurately detect when someone is concussed or non-concussed? And I don't think that's there yet. But then two, if you do have a concussed individual, is there a way to use that as a tool to make sure, and like, is there a cutoff that we can find to objectify quickly whether or not someone, because like you, I'm a PT, so I, my brain is thinking, okay, interventions, treatment, I definitely know to track there, but if there's a way to use it for one step beyond that, that would be really fascinating and of interest to me in my particular setting as well.
I would consider this to be a tool at this point as part of that multifaceted battery. As we expand our work and we're looking at the neural correlates, potentially it could provide a little bit more diagnostic accuracy in the future. But at this point, I also think they sell them or market themselves in this way. Abby, correct me if I'm wrong, but it's just a tool, part of a tool in your toolbox that provides some really interesting information. And it is honestly, when I learned about this tool and started using it, it is really, really cool to see the information that you get and how it aligns up with behavior. It's really remarkable. But Whitney and also anyone else on this call, we have a PDF handout of different exercises. So if you would like that, I'm more than happy to share it with you. It's what we did here. It has information on all the different exercises plus more and different modifications you can make. So we are more than happy to share that document if you'd like.
Great. Thank you so much. I really appreciate that.
Okie doke. I'm going to give a 3-second count to see if there's any other questions. I think this is great. I'm glad that there was such a lively discussion after the presentation, but I think that we're good now. Okay. So thank you again so much, Melissa and Abby. It was great to see you. Thank you for presenting your wonderful content. You can see how engaged we are. And I think we'll call it there with 3 minutes left to spare. Thank you everybody for joining. We'll see you at NABIS, IPIS, or ABIA.
Thank you.
Much for having us. Bye-bye.